Thank you, thank you, thank you. I want to just thank all of you for this opportunity to have a conversation with you and to talk about the state of affairs, the health situation in Shelby County. I wanted to thank Dean Joshi for the invitation. And let's proceed. So the introduction has already been given, so I don't really think we have this. We have it on. Well, I can use this. Oh, okay. All right. So there we go. So we're already going over my education, work experience, so I won't bore you with that anymore. Shelby County Health Department, we all know where this is our main office there on 814 Jefferson. And sorry, you may not can see this, but this is our organizational chart of the interim director. We have also deputy director, a chief of staff, Rudy Gray, and we also have the deputy director of environmental services. So here is the clinical services where we have community health. We have a Ryan White program, population health, office of innovation, then of course environmental services. So basically, there at the health department, y'all can hear me okay? Because I tend to move around, so that's the preacher in me. But so there's 470 employees that we have. We have 6 bureaus, 3 offices, and these are the areas that we focus on, of course, finance administration, clinical health, environmental health, epidemiology, informatics, nursing, allied health, population, et cetera. Ryan White program. And then we have some satellite facilities. So we're at 814, but we also have 5 satellite facilities in various areas there. Orange Mound, Hickory Hill area, Whitehaven, Shelby Crossing, that's off of Sycamore View, and Millerton. We also distribute food, supplemental food program, of course, our environmental services. And we're responsible for the forensic center. So the West Tennessee Forensic Center, we are responsible for overseeing it and hiring the medical examiners, et cetera. So the issues that we're concerned with, and this is what I want to spend some time talking about, are the social determinants of health, life expectancy, infant mortality, leading causes of death, HIV, mental health, substance misuse, homicide, and violence. These are the things I'm going to touch on just to kind of give you an overview of the health issues confronting Shelby County. Demographics of Shelby County, with 910,000 people, 910,530, in which 52% of the population African American and Black, roughly 32% white, 10%, 9.5, 10% Hispanic, 3% Asian. And also we look and see that the majority of the population younger than 45, so we have a fairly young population here in Shelby County. So if we talk about the determinants of health, so I like to refer to the World Health Organization's definition of health. The 40 years that I've practiced medicine, this has been the basis of how I view health, which simply is a state of complete physical, mental, social well-being, and not just simply the absence of disease or infirmity. And we see the influences. So there's the individual, but we see he's influenced by the family, of course, biology, but also behavior, psychosocial issues, environmental issues, the community, and even culture all plays a role in determining health. And so we've come to recognize that one's health is influenced by multiple factors, ranging from education, healthcare, access, the quality of healthcare you receive, but the neighborhood that you live in, the environment, the social and community settings, as well as economics. So we are familiar with this. I'm sure all of you conditions and circumstances which people are born, grow, work, live, worship, age. And these conditions and circumstances have a tremendous effect on one's health functioning and quality of outcomes. What is not taught, I think, enough is the fact that these factors are determined, are influenced greatly by policy and shaped by the distribution of money, power, resources, and are really responsible for the health inequities and disparities that we see among populations. To the point where, according to Robert Wood Johnson, 80% of these health outcomes are influenced by those social determinants, as opposed to just 20% of what we do in terms of actual medical care. So the Tennessee Commission on Children and Youth reports that out of the 95 counties in the state of Tennessee, Shelby County is 93rd in economic well-being, 91st education, 93rd in health, 74th in family and community. So the major issues confronting our children and our population as a whole: poverty, community violence, lead poisoning, mental health, inadequate prenatal care and nutrition, obesity, and unintentional injuries. Poverty is a major issue, a big problem in Shelby County that I think, again, is not addressed, not talked about. The fact that we see that children under 5, the percent living in poverty is 30, compared to the U.S. as a whole, 16.5. The point of not working now. But 31 point of roughly 32% 5 to 17-year-old versus 15. So poverty rate in Shelby County is, twice that of the national average. Now, that's for Shelby County as a whole. There are areas in Shelby County, in Memphis, where the poverty rate for children can be 70%, 75%. There's one area where it's almost 90%. There's a high poverty rate that's not addressed or mentioned in Shelby County. And we see this displayed here in this map. This map reflects the Health Equity Index. In Shelby County, of course, the darker areas represent the greater need, lighter areas, less need. 38139, 38138, that's Germantown. Germantown is the most wealthiest city, a municipality, not only in Shelby County, but in Tennessee and even nationally. And we see here, this is 3817 is Collierville, South Memphis, North Memphis. We can see the difference. I want you to remember this map because that same pattern, you're going to see it when it comes to other specific diseases and health outcomes. So to break that down even a little further, the Health Equity Index, Germantown, is 1. So each zip code is assigned a number. 38126, one of the poorest areas in Memphis, Shelby County, 99, the difference of 99. So the economic health index, some areas, is 99 times greater. The need is 99 times greater than, say, Germantown, Germantown. You see that even in, we look at a map of food insecurity, but very similar as well. Greater need, less need. So this, even though this is outdated 2015, I put this up here to show the relationship between economics and life expectancy. And so these blue dots, the measure of what they call economic hardship index, is a reflection of how difficult life is, looking at things like disability, economic, per capita income, education, employment, et cetera. So of course, the larger the dot, the greater the economic hardship, the more difficult life is. Darker colors represent the lower life expectancy. So you can see, again, that same pattern of that map we saw earlier, where South Memphis, North Memphis, life expectancy is shorter than out here. Matter of fact, it can be as much difference in some areas as 20 plus years. So if we look even here at a 5-year average, we see the same pattern. Life expectancy lower, as low as 65 years. Here, as high as 89.8, almost 90 years. It's about a 25-year difference almost. If my math is right. So if we look even more currently, 2020, from 2020 to 2024, we can see a disparity in life expectancy. Why is, so we want to, as you well noted, if you want to compare the health status of a given population, whether it's domestic or international, what have you, you look at life expectancy, you look at infant mortality, because those are two measures of how well a health system works, how well you're taking care of the least of these, how well you're providing basic health care, as well as the economics and other social economic factors. So we see here life expectancy, the differences that exist when we compare here, Shelby, Tennessee, and United States. And we also see the difference here between Blacks, whites, Hispanics. Life expectancy 69 versus 76 versus 81. We need to see what the Hispanic brothers and sisters are doing. They're living longer than all of us, right? Well, what's not depicted is the Asians is even a little better than that. So even when we look at infant mortality, pattern still looks just the same. That is, infant mortality rates are higher here, south, north versus out east. So infant mortality rates here, and what's interesting here is the infant mortality rates among Blacks in Shelby County is no different than Tennessee as a whole, and really not that much different than national. But if we look at the infant mortality rate on blacks compared to whites in Shelby County, 11.5, 3.9, 2.9, almost 3 times difference. Now, I put this up to show you that that disparity has existed for over 80 some years. And so you look back at, and even worse to some degree. So back in 1930, 32, the difference between life expectancy at that time, it was classified as non-white and white, right? Was 1.6, the difference. Over the years, though the infant mortality rate decreased for both populations, the difference, 3.1. So 11.9, that's not much different than what we just saw. What was it, 11.1? 3.9. This is, even though this is 2015. But I just want to show that that discrepancy we've known about for years. So we're going to see how these disparities in economics manifests itself in some specific health outcomes. So what we have here is a map of what we call the Memphis Transitional Grant Area. And it is 3 states, population of about 1.3 million people. And that's how we look at this HIV and a lot of the data that's recently you've seen in the media about our HIV rates. So the TGA really, of course, Shelby County is the largest part of that, but it's made up of other counties: Mississippi, DeSoto, Tunica, Tate, Marshall, in Arkansas, Crethan, and Tipton, and Fayetteville, along with Shelby. And so we look at the distribution, looks very similar to what we saw with the economic hardship and other factors. Here, higher rates than here. So there was a lot of report in the news about the fact that Memphis has the highest HIV rate of new HIV infections. And what that is that our rate was 31.4. We had, in this 2023, we had 419 cases, but our rate population divided into that put us at 31.4 compared to Miami, which was 29.8, compared to Atlanta, 24.8, and then some of the other cities. But this chart depicts that though we're at 31.4, more recent data that we have for 2024 actually showing that there's a decrease. This hasn't completely been confirmed yet, but it looked like there's a downward trend occurring. We're hoping that that is the case. So it's been estimated that in the Memphis metropolitan the TGA transitional grant area, that there are approximately 9,000 people living with HIV. And of those 9,000 people living with HIV, we see that 56% actually have HIV, and 43.9% has actually developed AIDS. One thing that's concerning us is that here, so for many years, the rate among Hispanic population has been uh, fairly low and steady. All of a sudden, from 21, it's jumped up from 21 to 56 per 100,000, even surpassing that of the African American rates. And so we see if you actually the prevalence of those living in Shelby County with HIV/AIDS, we can see that majority are indeed Black. Uh, and the age group that, and we're all really concerned that we see that it's 2024, 2020, so really 15 to 34 is an age group that comprise most of the people living with HIV. When we look further, we see that among this age group, especially the 15 to 34, the rates in the Memphis TGA 4 times that of the national average, and almost 3 times 2.6 for this age group. So we're really trying to figure out how do we reach this population to address the HIV issue. Of course, with HIV, we're concerned about the co-infections. And so we see that as much as of the 1,303 cases of syphilis, 19% of those also had HIV. And we can see same thing, 1% of those with chlamydia had HIV, 4% of the gonorrhea cases had also co-infected with HIV. And if we look again at the rates by race ethnicity, we can see African Americans have a much higher rate, almost 10 times that of whites. It is 10 times that of whites. Same thing here. When we look at age, it's that same age group that we're concerned about that comprise most of the cases. That age group is engaged in the behavior that contribute to both, to all of these, not only HIV, syphilis, but gonorrhea and chlamydia, we'll see. We are very concerned about congenital syphilis because there's been a rise. So in 2013, we had 1 case, now we're at 50 in 10 years. And of course, our rate 5.5 in comparison to the state overall, so we're about almost 5 times higher. And of course, you know, why we're concerned about the congenital syphilis, because the stillbirths and other complications that can occur. So we look at chlamydia, we see a similar picture as we see for syphilis. For gonorrhea, we see a similar thing as we see for syphilis. Again, the same age group that's at higher risk, higher rates. Chlamydia, same pattern. Age group, same. And so when we look at the map of looking at HIV incidents, if we look at the map, even going back to 2021, we can see how that map looked. Very similar. Higher rates here, decreased rates, lowest rates out here. And that pattern exists if we're looking at syphilis. looking at gonorrhea, look at chlamydia. Even when we look at mental health issues, similar pattern that we see areas that are in greater need, higher poverty issues, food insecurity, etc., higher economic hardship index, mental health needs are greater compared to out here. So even when we're looking at mental health concerns here in Shelby County, we see that one thing that got our attention is that high school students attempting suicide, our rates, Shelby County, almost 17% versus 13 for the state, 10 for the U.S. as country as a whole. So when we look at substance use, there is a downward trend for substance use. This is a chart looking at actually drug-induced death rates, true death rates over the years. And I throw this slide up here to just show you something that's very interesting. So over the years from 2017 to 2022, we can see the increase in death from suspected drug overdose. And what's interesting, in 2017, 68% of those deaths occurred in whites versus 31% in blacks. 2022 flipped. 37% occurred among whites, 61% among blacks. Some propose that the reason is that you begin to see a lot of fentanyl and other related use and deaths versus folks shooting up as one of those reasons why the demographics is changing. Also, I think that this is a reflection back here of the opioid issue is related to the fact of overprescribing of opioids and the population who was more likely to receive opioid medication. So to the point where now in 2023, we still see what that distribution looks like in terms of deaths, suspected deaths due to drug-induced deaths. And again, the map looks very similar where the deaths are occurring. Greater numbers here versus out east. So let's talk about homicide. So where are the homicide and what's the homicide rate? We know that violence is an issue here in Shelby County and Memphis. And we can see that these are the zip codes with the highest deaths due to homicide. And again, the pattern is very similar, higher rates versus lower rates. The point where we looked at suspected homicide rates per age group, of course, it's the younger people, again, 15 to 35, 44, but particularly the 15 to 24, 15 to 34-year-olds who are at greater risk. And even if you look at homicide by firearms, this pattern is still the same. 15 to 24-year-olds, 25, 34-year-olds. And if we look at this according to a race, see a major discrepancy in this, there, 67 versus 11, 6 times difference. And even if we look at the deaths by firearms, it's 6 times different. You know, so the question that should be asked, why? Going on there, where that the homicide rate among blacks 6 times that of whites. Blacks 6 times more likely to be violent, 6 times more likely to engage. It's a reflection of self-hatred, low self-esteem. What are the factors? Devaluing. And we just see that when we compare our rates to that of the national, we're 7 times higher. And we see that we're 4 times higher than that of the state. So what are we doing about it in terms of the health department? What are some of our programs that we're doing? And we see that we have, one of the things that we did, we had a church leaders health forum where we presented this information to church leaders, to pastors. We feel that to address some of these issues, we got to address hearts and minds. And we feel that the church and the faith community has a role to play. And so we invited, 53 pastors showed up, and we presented this information. And where our plan is to establish a task force consistent of church leaders and pastors to try to address some of these issues within their community and congregation. We conduct community fairs in those zip codes that are highest risk, high impact areas. We also have health and wellness programs that we emphasize. In our programs, in outreach activities, we have reached about 12,000, almost 13,000 people. TB elimination, nursing, and allied health, back to school immunizations. We do, of course, we do a flu pod. We also have our HPV vaccines, and we have actually had a 14% increase in the HPV vaccination, which outpaced the national average trend. Of course, our epidemiology is on top of things. We had a hand, foot, mouth outbreak here in Shelby County, which affected 279 students, 35 schools, and 11 daycares. Of course, we provide vital records. Environmental health services, we provide addressing the issue of lead poisoning, where we actually test the children, but also schools are required to report to us if their lead levels above 15 parts per billion. And we have recently started a podcast where we talk about the various health topics and activities and programs we have at the health department. Of course, we have HIV initiative. We have where you can actually go online and order a HIV testing kit, and it's delivered to your home. You go to 901 HIVtesting.com. And we also have a HIV summit, again, where we invite all of the players, the providers, the community-based organizations, and the Ryan White recipients to try to address this issue of HIV infection. Of course, population health. We even have a baby cafe, one of the few in the, in fact, we're the only one in the state that has one in the health department where we actually teach mothers about breastfeeding. We also have a fatherhood initiative where fathers are involved and take a role, encourage them to be involved and take a role in the care of the newborn. We're learning that the fathers play a major role in their involvement, is very important. And I'll stop and entertain any questions you may have.
Thank you for sharing that with Southern County. I'm just wondering, by any chance, do you have any statistics of the overdose in the last 2 years, 24 and 25?
Yeah, we do. And actually, the overdose rates are down. I actually meant to pull that up. I'm not sure if we can release those yet. They're still, but I get a report every month, and actually the numbers are less. Yeah. And then, and part of that we want to attribute to the fact that we have available naloxone, Narcan, and we have it in the vending machine. So we're planning on, we have one where you can come get it. We're gonna put others around, and fentanyl strips where you can test your stuff to make sure it's not tainted with fentanyl and that type. And we believe that that may be a contributing factor. Yeah.
That might demonstrate effectiveness of some of the harm reduction.
Yeah.
Or
Mm-hmm.
it's good to have numbers around that. Yeah. That's great.
Yeah. And I could probably get you those exact numbers, yeah, if you need it. But this it's down though significantly too. Just off the top of my head, I'm thinking that we were looking at where we had 519 deaths in 2023. I think we're down to like 3 something. Yeah, significant drop. Yeah.
So I would like to ask you 2 questions. One would be, what are the reasons the US is behind implementing structural programs to address health inequality? And second is, do you think we need to change our approach when it comes to tackling social inequalities to ultimately address these health inequity within populations?
Thank you. Absolutely. The health inequalities that we see simply a reflection of the inequalities that we see in our society overall. Politically, economically, educationally, etc. And until we address those, it's not going to be that much difference, to be honest with you. The first report that came out looking at minority health disparities were back in 1985 when the Secretary of Health and Human Services, Margaret Hatler, released the U.S. Task Force on Black and Minority Health. And if you go back and look at that in 1985, at the disparity that exists then and compare it to now, it will either be the same or may have gotten worse. until we make a commitment to social justice in terms of education, in terms of economic and people. I mean, one of the things that we look at this issue with poverty is need to pay people a livable wage. So it's our system that is contributing to the disparity that we see. The other part of that is that the United States, as you well know, is the only industrialized country that does not have a single source, a national health service or health program. I think that needs to change. But I've always, ever since I've been in medicine, I've been an advocate of the national health, single source national health program. You know, we spend a lot of money in our country on health care, and you're right, the outcome when we compare to other countries is poor in return. We're very good at providing high-tech Cadillac medicine for a few. You can afford it. We're not good at providing bicycle, Yugo type medicine for the majority of people. And so we really want to enhance the health status of all. You know, we need to address that. That's why that slide when I said about showed that it boils down to policy and the distribution of money, power, resources, influence. And I advocate everybody need to make healthcare more of an issue when people come around talking about and want to vote. So I don't know if that helps you. Yeah. Yes.
Well, I think that and it really shows great opportunity for here at the School of Public Health, what we can do in what areas I think will be intervening. And so I kind of have a question in a comment. My first question is, and it's very simple, what was the source of the data? If you can answer this.
So the source of CDC and the health department and Tennessee Department of Health. Yeah. So our epidemiology department puts together these slides. Yeah. And also, if you go to, and I should have had the slide, that's my, go to Healthy Shelby. So if you go to our website and click on Healthy Shelby, that all of this data would pop up. I mean, you can access it. Yeah.
Were they residential surveys? As in, did they go out to individual residents in Shelby County?
Oh, this is a lot of it is from the American Community Survey that they use. A lot of our information is like from death. So we have access to all of the death certificates, death reports, forensic centers provide us with the information.
Yeah. Because the data that you showed us for Shelby County really captured what we call the Hispanic paradox. And that's where you see greater and better outcomes for Hispanics compared to their counterparts. And there's a number of reasons for that. One of the big things is we look at social support networks. We also look at nutrition.
Right.
They're kind of the biggest factors that predict that boost for them. But as you get older, it kind of drops off sort of that effect. But the reason I asked the question about the survey is because it looks like it ended before 2025. I think it was 2024 was the latest.
Right.
And so I try to think about the bigger picture of what goes on in Shelby County in predicting these outcomes. And that was prior to, say, like the insurgence of governmental agencies here in Shelby County. And I think that that's a real big thing to think about when you look at that slide about mental health outcomes, because it shows an increase in mental health problems. It also shows increases in suicide rates. But what we're not capturing in the data are undocumented residents and
Right.
others in Memphis, Shelby County, where those rates are disproportionately higher, but they're never spoken.
Right.
And I think that this is one of those areas, again, especially post 2024. What can we,
Yeah.
what can we do for this group? Because that Hispanic paradox looks great on paper right now. We're not accounting for the folks, and that might be a totally different picture if we saw it. So that's one area that I think we can make some very awesome strides there.
And yeah, and you're absolutely right, is that I think that the Hispanic category is really misleading because all Hispanics are not all Hispanics, right? I mean, there's a difference between Puerto Rican, Cuban, Mexican, and what have you. We don't do a good job in breaking down that. And what we don't have is the data looking at the indigenous population. And I'm just learning that there's a significant indigenous population here in Shelby County that health issues are quite different. Even the poverty rate, if we look at native indigenous people in Shelby County, their poverty rate is even higher than that of blacks. Yeah, so you're absolutely right. One thing too is keep in mind is the data usually is probably 3 years behind. As you can see, we only got 24, and all of it is not finalized. So. Mm-hmm. Yeah.
And we're gonna close it up there. Ask Dean Joshi to come briefly before we close out.
Thank you so much, Dr. Randolph. I think this was enlightening and also actually challenging us at the School of Public Health, especially for the students and the faculty to see how we can actually do our part to look the map differently than what it is right now. And I think it gives us a lot of room for us to think through about some of the priority areas that you might have, where you feel that our students could be a great resource to help you, whether it's part of the experiential learning effort, whether it's programmatic evaluation, whether it is even survey or data collection, whether it is, I just want to let you know that we are a resource here available to support the Shelby County Health Department to attain its vision under your able leadership to moving good health and well-being for all. That's one. The second thing, what was very interesting that actually, Alex, you brought this up, is about the issue of mental health. As we have a community stress and well-being lab here, where we are engaging the students, I think that might be another opportunity for us to look through specifically some of the areas that you might feel that might help. And third thing, which was not I have prepared, frankly speaking, I'm going to say that. I saw very interesting that you have an HIV summit that you are doing every year. I throw something at you for you to think through. Maybe having a public health, Shelby County Health Department, School of Public Health, some public health summit issues impacting Shelby County. That might be something that raises awareness, which allows us to bring a lot of community partners, a lot of organizations, and we would love to host here at the School of Public Health with your support. I think that might be also to sensitize not just the students from the School of Public Health, but we have students from social work, nursing, and other areas that might be open to thinking about public health from that lens. So this is something I would see if there's an opportunity to organize something like that as an annual summit around, which could be between the School of Public Health and the Shelby County Health Department. I think this will also help our students, our faculty gauge about the great work that you are initiating, but also at the same time will help us to identify where we as a School of Public Health can contribute to make our gaps, fill those gaps. The last is that I would say that we have faculty here who have the expertise and the commitment, the willingness to take it to the next level. What might be very helpful for us is if you think that there are 3 to 5 priority areas that you really feel that this is something very important and we do need some real support from the students in terms of experiential learning projects, we would love to prioritize rather than doing A compared to what you're looking for B. We want to make sure that we are aligning ourselves to your needs and your priorities. So I just want to make sure that we are offering this as a resource to School of Public Health. And lastly, I would say that the School of Public Health has to go beyond the walls of its academia. Our goal is to support the Shelby County Health Department to basically bring those programs, policies into practice. And that's where we see our role and bringing the best practices from what we are looking from the academic lens that could serve as a catalyst to help attain the goals that you're planning to accomplish. So with that note, I just want to thank everybody who took the time, but more importantly, really thank you for coming in. I just want to emphasize that I've been here now this is 4th year. The constant support and the continued support of Dr. Randolph has been very encouraging, and I'm very, very grateful to you personally that you have actually extended yourself to all when we have reached out to you. And I hope that we come up to your expectations to deliver the best what we can on behalf of the School of Public Health here for the Shelby County Health Department. So with that note, Victoria, thank you so much. I just would like to take this moment to give a small token of appreciation from the School of Public Health.
Thank you,
For
sir.
your able support and leadership.
Thank you very much. Appreciate it.
Yeah. Thank you all. Thank you very, very much for your support.
Thank you all, everyone, so much for coming. And just want to remind you, our next series will be on Friday, March the 20th, where we'll have representation from opioid response, public health, and population health. So thank you all so much and have a great week.